Hello everyone, welcome back. Today we will learn about the treatment of chronic obstructive pulmonary disease, which is caused by long-term exposure to irritants like cigarette smoke or air pollution. The aim of COPD management is not only to reduce symptoms, but also to prevent disease progression and improve the quality of life for patients. The treatment of COPD is typically divided into three main categories: pharmacological treatments, non-pharmacological approaches, and interventional and surgical therapies. Starting with pharmacological treatment, patients are classified into three groups: Group A, Group B, and Group E, according to the GOLD symptom assessment tool. This classification helps guide treatment decisions. Group A patients who have minimal symptoms and are at a low risk of exacerbation should be offered bronchodilator treatment, typically a long-acting bronchodilator, LABA or LAMA, like tiotropium or formoterol. Group B patients, those with significant symptoms but a low risk of exacerbations, should be initiated on a combination of a long-acting beta-2 agonist and a long-acting muscarinic antagonist, LABA plus LAMA, for example, tiotropium or glycopyrronium and formoterol. Group E patients who have symptoms and a history of frequent exacerbations should consider a triple combination therapy of a long-acting beta-2 agonist, a long-acting muscarinic antagonist, and inhaled corticosteroids, LABA plus LAMA plus ICS, especially if their blood eosinophil count is equal to or more than 300 cells per microliter. The use of LABA plus ICS in COPD is no longer encouraged. However, add-on drugs like low-dose sustained-release theophylline, roflumilast, and N-acetylcysteine can be used in a few selected patients. Moving on to non-pharmacological approaches, the first focus here is on minimizing exposure to risk factors. To begin with, this includes smoking cessation. Smoking cessation is a crucial intervention for all COPD patients who smoke, with even brief periods of counseling by a physician proving beneficial. Reducing household and outdoor air pollution. By efficient ventilation, non-polluting cooking stoves, and similar interventions are feasible and should be recommended. Pulmonary rehabilitation is known to improve dyspnea, reduce hospitalization, and alleviate symptoms of anxiety and depression in COPD patients with a high symptom burden and risk of exacerbations. Long-term administration of oxygen for more than 15 hours per day has been shown to increase survival in patients with severe resting hypoxemia. Non-invasive ventilation, NIV, is occasionally used in patients with stable, very severe COPD with daytime hypercapnia. Nutritional support. Malnutrition has been reported in 30 to 60% of patients hospitalized with COPD. Supplementation of nutrition has been shown to improve patients' conditions. Vaccinations. People with COPD should receive all recommended vaccinations like a yearly influenza vaccine, pneumococcal vaccination, new respiratory syncytial virus vaccine. The CDC also recommends the Tdap vaccination for COPD patients. Lastly, we have interventional and surgical therapies. These are reserved for patients with severe COPD who do not respond adequately to pharmacological treatments and non-pharmacological approaches. These include bronchoscopic interventions to reduce lung volume using one-way valves and coils, lung volume reduction surgeries, surgical bulectomy, and lung transplantation. In addition to these approaches, managing COPD involves treating exacerbations and addressing comorbidities. Treating exacerbations requires a unique approach, and managing comorbidities is equally crucial. Unless these are managed appropriately, the aim of COPD treatment cannot be achieved. Therefore, these topics will be covered separately in another video, so please subscribe. In summary, the treatment of COPD is multifaceted and unique to each patient. Hence, treatment plans should be tailored to meet individual needs and circumstances.